So today we're talking about wrist and hand. So let's start with a little bit of an overview. So we're going to talk about some acute conditions and chronic conditions. So in acute conditions, we'll mostly talk about fractures and some torn ligaments and how they appear on radiographs. In chronic conditions, we're going to be talking about some diseases like rheumatoid arthritis or osteoarthritis, how they're different from one another, and we're going to talk about some other special conditions as well, like psoriatic arthritis, which is rare but is very severe and debilitating disease. So we're going to look at all of these conditions step by step, all the acute and chronic ones. So I hope you enjoy. So let's start. So first we're going to talk about acute conditions and trauma. So mostly all of the acute conditions are as a result of some trauma or injury which has abruptly happened, and as a result there is some fracture or some soft tissue injury or some like soft tissue injury like a torn ligament. So there are different types of fractures. If we're talking selectively about the wrist, then there are certain types of fractures which we will discuss depending on the gender and especially on the age. Some fractures are especially for the children and others are common in adults. So there are different conditions depending on different traits and the location of which we're going to talk about. So in today's lecture, we're focusing on wrist. So the acute conditions for wrist can be if you fall on an outstretched hand, which can actually damage your elbow, your shoulder, but we're going to focus on the wrist. So what happens in wrist is that your scaphoid fractures are very common when you fall on an outstretched hand. So other fractures are also common, but scaphoid fractures are very common. So we're going to look how they appear on radiographs as well. So let's start. So first of all, we're going to see what the presentation of acute conditions are like. So that's very important. So when somebody presents after a fall or some trauma, they are usually complaining of pain. So that's the first symptom is pain. Obviously, there is severe pain with a fracture or some torn ligament, and with that there will be bruising or swelling. So bruising is one of the first presentations after a trauma or injury. So then pain. So pain and bruising will be the presenting complaints. Then deformity can be an acute condition. It can also be regarded to as a chronic condition. But if the deformity is chronic, but the pain has started abruptly, then it's probably because of some acute changes within the joint, or if there is acute swelling of a deformed joint, then it is also under the acute domain of injury. So deformity with some acute swelling or acute pain, and then swelling. So swelling usually appears a little bit later than bruising or especially pain. Pain is the first after you fall. The first thing that you're going to experience is pain. So these are some of the presenting complaints of people after some acute trauma. So all of these conditions, if somebody presents with these conditions, the first thing that we do is we examine, and radiography or an X-ray is advised with on presentation. So before we go to the interpretations of on radiographs of different fractures, let's look into the views, different X-ray views in which the wrist is X-rayed. So first we have the PA view, which is the ideal view, and it is mostly advised on whenever somebody presents with any condition, the PA view is asked for. So what happens in how the things appear in a PA view, let's look at that. So this is the is the radius bone. So radius is the bone which is the one which is on the thumb side of the hand. So this is the radius and this is the ulna. So in anatomical position, when it's very important to talk in anatomical reference, taking in view the anatomical placement of the bones. So this is the anatomical presentation. So this, if I put my hand like this, so this is the anatomical presentation. So this is actually the lateral bone. So the radius is the lateral bone and the ulna is the medial bone. So that is what I'm actually focusing on, to know that radius is actually the lateral bone and ulna is the medial bone. So here in PA view, so this is how the hand is placed on the cassette or the bucky, and the x-rays are falling on the hand from a 90-degree angle. So the picture that we're going to get is this is the focus for a radiograph of the wrist. So this is the radius bone, but this is the lateral bone, talking in anatomical position. So this is actually the medial bone, which is actually opposite in this case because my hand is prone. So when we refer to bones in anatomical position, this is the supination of hand is the anatomical position. So when my hand is in pronation and it is being x-rayed, we will call this bone lateral bone and this is the medial bone. So it is very important to know this difference. So the medial bone is my radius bone and ulna is my lateral bone in this condition, but that is not the anatomical condition. So this is pronation. So here, this radiograph is a PA view. So this is how it's taken. But when we're going to be commenting on it, we will say the lateral bone radius is this one. The medial bone ulna is this one. So this is because of the anatomical position. So I hope that's clear. So this is the first metatarsal, this is the second metatarsal, the third, the fourth, and the fifth. So I talked about the metatarsals before carpals because it's going to be a little bit confusing. And then we have the phalanges, the proximal and the distal phalanges, the joints as well. So this is a metacarpophalangeal joint. This is the first row of phalanges, and then we have this here. Only one is visible. The others are not visible in this picture, but we'll discuss them in later radiographs. So this is the metacarpophalangeal joint. This is the interphalangeal joint, the proximal interphalangeal joint, and then we have a distal interphalangeal joint as well. So these are the carpal bones. So when we're naming carpal bones, we move from lateral to medial. So it is the bone with radius and the thumb. So this is the lateral one. So the first is scaphoid. So it's scaphoid. And then we have she looks too pretty, try to catch her is the mnemonic that we use. There are a lot of other ones as well, some cheeky ones out there, but this is the most widely accepted. So she looks too pretty, so that's like scaphoid, lunate, tricutrium, and then we have pisiform. Pisiform is the last carpal bone to ossify, and in a child below the age of 12, the pisiform carpal bone is not ossified and is not visible. So this is an adult x-ray. So we have scaphoid, we have lunate, we have tricutrium, and then we have pisiform. So, and the upper row we have try to catcher, so it's TM and then TD. So it's tricutrium, trapezoid, then we have capitate and hamate. Hamate is the last of the carpal bones. So the carpal bones are visible. This here is the hamate. We'll look into a better, clearer picture to visualize all of the carpal bones in detail. So then we have this oblique PA view. So this is when you place it like this. Either you place your hand at a 45-degree angle, or it's better if the X-ray tube is moved at a rather 45-degree angle to get this oblique PA view. Then we have the lateral view. So in lateral view, the hand is placed like this with the thumb sort of in this position and not like this. So this is the placement of the for the lateral view. So these are the three views of wrist, and now we're going to look at some of the supplementary views, which are the special views of wrist. So wrist special view is when we suspect some complex injury, we because of the very close proximity of all the bones in the wrist, the 8 carpal bones and the radius and ulna are sometimes overlapping in almost every view. So we actually ask for some special views in some certain conditions. So. Two special views are first the scaphoid view. So this is to visualize the scaphoid bone. So this is the scaphoid bone, which is here we can better visualize the carpal bones. So we're going to actually label them here and learn how to identify which carpal bone is where. So this is the radius and this is the ulna, right? So this is the scaphoid bone, the first carpal bone. And moving from lateral to medial, let's name them. So this is scaphoid, then we have lunate, then we have tricutrium, and then pisiform. This is the last to ossify. Then again, we move from lateral to medial. So trapezoid, and trapezium. Then we have capitate and hamate. So capitate is the biggest of the carpal bones. So this is how we name all of them. And again, I will repeat the mnemonic here. So this is she looks too pretty, try to catch her. So she is S is for scaphoid. So this is scaphoid. Looks L, so lunate. And then we have too pretty, so that is tricutrium, and then we have pisiform. So that is the lower row of carpal bones. So these are 4, and the upper row again 4. So we're going to move from lateral to medial again. So lateral is the first upper lateral carpal bone is trapezium, and then we have trapezoid. So TM, and after that TD. So these two here, and then we have capitate, which is try to catch her. So this is capitate, C catch, and C for capitate, and then hamate. So that is all for the 8 carpal bones. So we discussed in the previous PA view the metacarpals and the phalanges and the radius and ulna bone. So these are the carpal bones, and the joint surfaces are this here, these, and there are a lot of different ligaments attached to these surfaces as well. So the intra-articular disc is present here between the scaphoid, between this scaphoid bone and this lunate bone, and this is the radius bone. So the intra-articular disc is present here, and this is the radius and ulna. So that is all of the anatomy and how carpal bones are labeled on a radiograph. So here also, let's just quickly look at them as well. So this is 1, 2, 3, and 4. This is pisiform, so scaphoid, lunate, tricutrium, and pisiform. So this is lateral to medial, and then we have, this is scaphoid, right? So then again, we move lateral to medial. So this is trapezium, sorry. So this is tricutrium, and this is trapezium. So trapezium, trapezoid, then we have capitate and hamate. So these are 8 carpal bones. So this is the scaphoid view to better visualize the scaphoid bone. How to actually get this view? What we do is we place the arm on the bucky like this, and the X-ray tube is placed at a 10 to 15 degree angle, and then the center point is actually focused on the scaphoid bone. So here, this is the scaphoid bone, and this is the point that is focused by the X-ray tube. So that is how we obtain the scaphoid view to visualize the scaphoid carpal bone. So it's also a subcategory of the PA or posterior anterior view. So posterior anterior, like we talked about in previous videos as well. So PA view is actually posterior anterior, in which your placement is such that the cassette is beneath your anterior surface, and the x-rays are going into your body from the posterior surface. Because this is the posterior surface, talking with reference to the anatomical positioning of the body, which is very important to remember, and that is why I'm stressing on this. So this is the posterior surface of my hand, considering the anatomical or taking the anatomical position as a reference. So this is posterior, so the x-rays are going in from the posterior surface and falling on the bucky from the anterior surface. This is how a hand is placed for a PA x-ray view. So then the second supplementary view that is asked is a one with radius or ulnar deviation. So the deviation towards the radius bone is called radial deviation, which is also called lateral deviation, and the deviation towards the ulna, also known as medial deviation. So one can also ask for x-ray views in this position. So this, if my hand is placed like this towards the ulna bone, it is bent towards the ulna bone. So this is lateral deviation. I'm sorry, this is medial deviation towards the ulna. Ulna is the medial bone, so this is medial deviation. And so this, in this medial deviation, if I place it like this in a PA position, for a PA view, I place it in with my posterior surface towards the X-ray and my anterior surface towards the bucky. So this is the placement for a ulnar deviation PA view. And when I do it like this, this is the placement for a radial deviation or the lateral deviation PA view for an X-ray. So these are all the carpal bones here. So what happens is this is a radial deviation, right? So the deviation is towards these metacarpal bones are moving or are displaced in this direction, and this space here is more than normal. So this is a radial deviation x-ray. So what happens here is that the upper row of carpals actually move towards the direction of movement, and the lower row of carpals are moving away from the direction of movement. So the movement is happening in this direction towards the radius bone. So radius is the lateral bone, so this is lateral deviation, and these metacarpals and the upper row of carpal bones are moving towards the movement direction, and the lower row of carpals are moving away from the movement direction. So these are pointed away. So I hope that's clear. I tried my best to explain it the best to my ability. So these are all the views and how the carpal bones appear on the radiographs. You can use different mnemonics to remember the sequence of the carpal bones, and it is very important to remember that the upper row moves towards the movement direction, moves in the movement direction, or towards the movement direction, and the lower row moves away from the movement direction when we're talking about lateral and medial deviation. So that is it for the radiological views. Now we're going to focus on specific conditions. So first of all, we're going to talk about non-displaced scaphoid fracture. So the scaphoid is one of the carpal bones, as we saw on the radiographs, and we labeled it. We're going to do it again with practice. Hopefully everybody will understand. So non-displaced, meaning of non-displaced is that it is not it is still in its anatomical placement. It is not outside of that placement. It is not in a fragmented form. So we'll see how that appears on the radiographs. So here we have an X-ray view, which is a PA view, which is a posterior anterior view. Let's revise it again because it's very important for everyone to understand. So this is the scaphoid bone. Let's just right now focus on nothing but the anatomy. So this is the radius. This is the ulna. Radius is the lateral bone anatomically, and ulna is the medial bone anatomically. Here it appears medially and laterally. This is the left hand of an individual, and here it appears that this is medial and lateral, but that is because it's placed in the PA placement. Its placement is like this. So this is the radius, the ulna bone. Then we have two rows of carpal bones. The lower row, or the first row, or the proximal row, whatever you want to call it, is of 4 carpal bones. First is scaphoid. So this entire bone is scaphoid. Then we have lunate, which is the lower row, middle, which is present in the middle, because the tricutrium and pisiform are very almost very like joined together. So they are in the far lateral placement, or far medial, actually anatomically far medial placement. And so in the middle we have lunate. So this is lunate, scaphoid, entire bone. This is scaphoid. Right now let's ignore this fracture line. So this is scaphoid. Then we have lunate. Then we have tricutrium, and then we have, this is a small pisiform bone. So this is, we go from lateral to medial, right? We go from radial side to the ulnar side. So these two are in the far medial side. These are two bones, but these are far medial. So this second proximal carpal bone appears to be in the middle. So then we have the upper row. So for the upper row, this is the entire scaphoid bone. So ignore that this is right now in this radiograph appears to be two different bones. This is because this is a fracture line. So this is a fracture line, but if it were not here, so this would be a complete scaphoid bone here. So these are the boundaries of the scaphoid bone. So let's now go towards the distal row, or the second row, or the distant row of the carpal bones. So again, moving from lateral to medial, let's name it. So this is trapezium. So this is trapezium, and then trapezoid. Then we have capitate and hamate. So this is the last, the 8th carpal bone, or the last of the 4 upper row, or the distal row of carpal bones. So I hope carpal bones can be now labeled on a radiograph by everybody who is looking in or listening to this lecture. So these are all this is how the placement of carpal bones is visualized on an X-ray. So let's now focus on this fracture line here. So this is a scaphoid through and through fracture, but it is not displaced. It is actually a through and through fracture, but it would be displaced if this fragment was either touching the radial head, or this fragment was actually inverted on its side, or because of some ligamentous pull was not in its anatomical position. So right now it is in its anatomical position and is not displaced. So if we join these boundaries, this will actually form a very the anatomical boundaries of the scaphoid bone, very continuous boundaries if we join these lines. So this is not a displaced fracture. So this is a scaphoid through and through, non-displaced fracture present in the wrist, in the carpal bones, the first carpal bone. So For that, you immediately immobilize the joint because you do not want the fragments to be displaced, because a displaced fracture will obviously be more complicated, and it will actually damage the structures that are in close proximity to the fracture site. So what we do is we instantly or immediately we immobilize the joint. So that is a little bit about the non-displaced scaphoid fractures. So now we're going to talk a little bit about TFCC tear, which is a triangular fibrocartilaginous complex. We'll see how that is formed and what the resultant tear does. So first, let's talk about the anatomy of the TFCC. So this is the carpal bones, the first metacarpal, which is visible here. This is the radius bone here, and the ulna. So a couple of ligaments, 4 to be exact, are attached to the ulna, the radius, and the carpals and metacarpal bones, and they form the triangular fibrocartilaginous complex. So the most important is among all those 4 ligaments is this one, which is the radio-ulnar ligament. So this is the ulna and the radius, and this joining the 2 bones, the 2 distal portions of the radius and ulna, is the radio-ulnar ligament. So again, ligament bone connects the bone to another bone. So this is a radio-ulnar ligament. This here is the right above the ulna bone is the ulnar collateral ligament, also part of the TFC complex. So other 2 ligaments that are also part of this complex are, so first let's name these carpal bones so that we can talk about the other 2 ligaments. So first, let's go from lateral to medial. So this is the scaphoid bone. This is the lunate bone, which appears to be in the center, although this should be here because of the tricutrium and the pisiform, very small in size and pushed towards the medial side. So this second carpal bone in the lower row appears to be in the center. So this is scaphoid, then we have lunate, then we have tricutrium, and pisiform is not visible here. So again, moving from lateral to medial, the carpal bones are trapezium, so TM, then we have TZ, trapezoid, then we have capitate and hemate. So these are the 8 carpal bones. Pisiform is not visible. So ulna attaches to the lunate, forming ulno-lunate ligament, which is the 3rd TFC complex ligament, and then it attaches to the tricutrium here. So that is the ulnotricutrial ligament. So now let's, so this is the tricutrium, like we just labeled. So this is the triangular fibrocartilage complex, the ulna bone here, and the lunate carpal bone, and the radius. So these 4 ligaments, the radio-ulnar ligament, the ulnar collateral ligament, the ulnotricutrial ligament, and the ulno-lunate ligament form the TFC complex. So tear of each of these, any of these, or all of these results in a TFC complex, and depending on how many and what form of tear it is, we call it severe rupture or severe tear or a complete tear, depending on how many of these ligaments are involved and what is the severity of their involvement. So now that we have discussed the anatomy, let's see how it appears on radiographs. So this is an MRI image. So here, this is the ulnar bone and the radial bone. So the ulnar bone, the ulnar collateral ligament is here. The ulnolunate ligament is here. The ulnotricutrial ligament is here. So in this specific case, the radio-ulnar ligaments seems to not be involved. So it it seems as if it's not involved. So the other 3 ligaments, which is again the ulnar collateral ligament, the ulnar tricutrial ligament, the ulnar lunate ligament, or the ulno-lunate ligament and ulno-tricutrial ligament, they are involved. So this is the rupture site here. So, and obviously this is where the ulnar collateral ligament is present. So this is the rupture site here. So this is the blood also visible here, some clot formation. So this is how it presents on an MRI. Then we have here again the same case here. So this ulnar collateral ligament is moving from, this is the ulnar collateral ligament, which is torn here, and also with it the ulno-tricutrial or the ulno-lunate ligament are involved as well, but the radio-ulnar ligament is intact. So the 3 ligaments are ruptured here. So this is a TFCC or the TFC complex tear which is involving 3 ligaments. So this actually the diagnosis is based also upon the site which is painful, or the site which is which has a very limited amount of ROMs. So this is the ulnar site, right? So if ulnar site is involved, the movement limitations will be the ulnar deviation. So the ulnar deviation will be limited, and there will be pain on any movement towards the ulna, and the pain will be localized to the ulnar area of the wrist. So that is how you reach to a diagnosis. You can't just look at a radiograph without knowing the history of the patient or the presenting complaints of the patient and give your diagnosis. So it is very important that you know the history, you know the presenting complaints, and then you look at radiographs to have a better understanding. So these 2 are MRIs. Then we move to a CT scan. So this is a CT scan. And here, again, this is the radius and ulna. So the focus is on ulna here. So the ulnar collateral ligament is damaged here. The ligaments attaching the tricutrium and lunate are also damaged here. So this is the same case, and a CT scan of the same case. So we can see the ligament rupture. Then now let's talk about the other types of fractures. So Colles fracture is a fracture commonly seen in adults. It is a fracture of distal radius, and the distal radius is obviously the radius that is forming the wrist joint here. So what happens is that because of the fracture site, it's a through and through fracture of the radial head, and what happens is the radial head is moved in a posterior direction, and the resultant deformities is often referred to as a dinner fork deformity. So because it's because of its presentation, obviously I can't make that because I don't have a fracture here right now. So, but if I did, so let's just actually explain it here. So what happens is this fracture site will appear in a way that this will be moved downwards. So it will actually impinge any structure that is passing through here. So this is a perfect perfect description of the thing that I was trying to explain. So dinner fork is the shape of a dinner fork, right? So it's like this. I wish I had a fork right now, but just imagine a fork and then look at this. So this is the fork-like presentation here. So what is happening is that it's a through and through fracture here. So this is an entire through and through fracture of the radial head, and the radial head is displaced. It's a displaced fracture, and the fracture is impinging any structure that is present anterior to the fracture site. Also, the posterior structures will also be damaged, but the anterior damage will be more. The median nerve is passing through the or underneath the flexor retinaculum, as we know. So there is a very increased or high chance that the median nerve will be damaged here, and then it'll result in a in further complicating the condition. So this is how the Colles fracture presents. Again, it is caused when a person falls either on the hand in this position, and because of that it can result, or if something hits the arm directly, Colles fracture can result. Mostly when you fall on an outstretched hand, the scaphoid is damaged, but it can also be accompanied with a Colles fracture, but that's rare. Mostly it's because of direct blow to this part of the wrist or the hand. So again, let's just repeat it again because this is a very important topic. So Colles fracture is when the distal radial head is fractured through and through, and its position is such that it impinges the structures that are present in the anterior surface or this interior retinaculum surface. The median nerve is the median nerve damage is expected. So this is, and the presentation is like a dinner fork. So this will be this portion will be moved upward, and there will be a depression here and then a swelling here. So then my hand will look like a dinner fork if I had a Colles fracture. So that is all about Colles fracture. Now we're going to talk about intra-articular fractures of the distal radius. So Colles fracture is not an intra-articular fracture because it's the fracture of the neck of distal radius, or the distal radius head is fractured, and I will explain what the intra-articular fracture is and how that's different, but it's better that I explain on a radiograph. So this is the intra-articular surface, right? So what actually is the intra-articular surface? Intra-articular surface is the surface which is forming the joint or is present inside the joint capsule, right? So this surface is the intra-articular surface. It can be of any bone, radius, ulna, the carpal bones which are forming the wrist joint. So these surfaces here, this surface here, and this surface here and here. So if these surfaces within the joint capsule are fractured, we call it a intra-articular fracture. And how that's different from an extra-articular fracture? Well, this is an extra-articular fracture, and it is not inside the capsule of the fracture, inside the capsule of the joint, and this fracture is not connected in any way to this surface. So if it were a fracture here to here, then we would have called it an intra-articular fracture, like this one. So this is an intra-articular fracture because it's a fracture of the neck, or even it can, if it extends to the shaft, it can be a fracture of both the neck, the shaft. But because it is going inside the joint capsule, or is also including in the fracture the intra-articular surface, we call it an intra-articular fracture. And because this is not involving in any way this surface of the joint, so we call it extra-articular fracture, or outside the joint fracture. So it too can involve the shaft, the neck, or any part of the bone which is outside the joint capsule or joint forming surfaces of the bone. So this is all about the extra and intra-articular fractures of the radius. So let's see. This is the fracture line of the radius, and also the intra-articular fracture line, we can call it. So this is a comminuted distal radius fracture. Also, we can call it extra-articular comminuted distal radius fracture. Distal radius because, well, the proximal radius is in the elbow, and this is the distal radius that forms the wrist joint. So Now we're going to talk about incomplete or buckle neck or buckle fractures. These are fractures which are common in the neck region of long bone. What happens is that because these are common in children, so we talked about them in the introductory section of the lecture. So what happens is that children have a thicker periosteal layer, right? So when under stressful conditions, what happens is before any fracture or breakage of the bone actually bends, and the fracture is not a complete through and through fracture. We call it a Greenwich fracture, and it is a little bit different from buckle fracture because in Greenwich fracture, it's an incomplete fracture, but there's no bending. It happens because of the bending phenomena, and that's the same. But an incomplete buckle fracture is the one where we can actually see a sort of like a bend in the bone. So let's see how that appears on the radiograph for better understanding. So like I said, it's common in the neck. So this is the neck of the radius, and also because it's common in children, this is the bones have not completely ossified, as you can see here and here. So this is a child's radiograph, child's x-ray, but this kid is above the age of 12 because all the 1, 2, 3, 4, 5, 6, 7, oh, actually these are 7. So this is probably a kid below the age of 12. So if there were 8, then the kid would probably have been somebody above the age of 12. So this is a kid who is below the age of 12, and there is no complete ossification yet, and this is the buckle fracture. So what happens here is there is a bend and an incomplete fracture line here. So this is how the buckle fracture appears on radiograph. There is a bend there is a like a protrusion in the fracture area or the area that is involved. Again, so this was a PA view, and this is a lateral view. So in a lateral view, we can see again the protrusion or the bend here, and the fracture is actually not visible here, but is actually visible here. So here we can only see this little bend in the bone, but here we can also visualize the fracture line. So that is the incomplete buckle fracture and how it appears on X-ray. Now we're going to talk about scaphoid fractures. We've been focusing on how scaphoid is fractured when you fall on an outstretched hand, and we are now going to see how it appears on an MRI because scaphoid fractures can be missed on X-rays. These are very small bones, and these are very closely linked bones, and they're overlapping each other. No matter what view you're looking at the bones with. I mean, it's a PA. If we are looking at it in a PA view or lateral view or oblique view. For scaphoid, actually, we have a special scaphoid view for it too, but even then, scaphoid fractures or the carpal fractures or fractures that are involving structures within the wrist joint can be missed because of the complexity of the joint. There are a lot of surfaces that make the wrist joint, and a lot of joint surfaces of different bones that are making this joint. So let's see how they appear on a radiograph and then on an MRI. So this is a PA radiograph. So it's very easy for someone to miss this fracture here because it's not visible on the radiograph, not very visible on the radiograph. This is a child's X-ray again because there is no complete ossification. There is a cartilage present here, which is not visualized on the X-ray by the X-rays. So this is the X-ray of a child, and 1, 2, 3, 4, 5, 6, 7, 8. So this is a child's X-ray whose age is probably above 12. So now let's see how like I said, there is no visible fracture of scaphoid here, so it can be easily missed. You have to be you have to be a very good radiologist or a very pro to actually diagnose a fracture here. But if you look at the T1 sequence of an MRI, it's pretty visible here. So this is an entire through and through fracture here, which is not visible here at all. So this entire region, it's fractured here, and it is actually going to it is passing this entire region, and it is actually fractured through and through. The entire scaphoid is fractured from here to here, which is not visible on an X-ray. So this is probably taken some 1 week or more after this X-ray, and somebody probably just said that you're okay, there's just maybe a soft tissue injury, and maybe sent the kid home, and the kid, because of pain, came back, and an MRI shows a fracture. So like I said, history is important, and sometimes X-rays don't really show a lot of fractures on presentation, and you have to really be a good practitioner, or know the fractures and the type of fractures that are present in kids or adults, and you have to know what modalities can easily diagnose them. If there is excessive pain and if there is no fracture visible on an X-ray, then CT or an MRI is definitely the next option. So this is a fracture of mid-scaphoid, sorry. So this is a mid-scaphoid fracture. It's a through and through fracture. And now we're going to talk about the scapholunate ligament. So the scaphoid and the lunate, these are two carpal bones, and these are two carpal bones which are next to one another. So let's see how they're connected, and how the ligament. So ligament, again, connecting bone to bone, connecting the scaphoid to lunate, and how tiers of that ligament will present on radiograph. It's important to mention here that the scapholunate ligament is actually responsible for the stability in the joint, because there are 8 carpal bones, and if there is any ligament tear, obviously there will be disruption in the biomechanics of the bones, because like I said, if I am radially deviating, so this is my thumb, and with that is my radial bone, which is the lateral bone. Again, I'm stressing because this is very confusing, and I get confused too, so one should pay more focus on that. So this is my thumb, and with that my radius bone. This is the lateral bone, and when I'm deviating my hand towards the radius bone, this is lateral deviation of arm. So what is happening here is that my lower carpal bones are moving away, and my upper carpal bones are moving towards the movement. So when I'm doing this, the upper row is moving towards this movement direction, and the lower is moving away from this, from the movement direction. So the lower bones, the scaphoid to the pisiform, are moving away, and the upper row is moving towards, from trapezium to hemates. These are moving, the upper row is moving towards the movement direction. So if there is any ligament tear within these 8 carpal bones, obviously there will be a biomechanical disadvantage, and the movement will not be proper, and obviously then these movements will be painful because of the complex joint movements, because an entire row is moving away from the joint or the movement direction, and the upper or the distal row is moving towards the movement direction. So if a ligament that is joining the scaphoid to the lunate is damaged, then the movement of the scaphoid and the lunate away from the movement direction will not be proper, and if they don't move away, then there's not really a space here for the upper carpal bones to move here. So for the upper carpal bones to move in this direction, the space has to be created by the lower row in moving away. So I hope I have explained it enough for everyone to understand. So if the lower row can't move away, then there is no room for the upper row of carpal bones to actually fill the gap, and the movement will not result. So this is what happens if there is any torn ligament within these carpal bones. So now let's look at the radiograph. So how this appears on a radiograph is, like I said, these are actually ligaments are joining the bones from two bones, right? So this is a lunate and scaphoid, the two carpal bones of the lower row. So these are joined together, and if there is a ligament tear like here, so what will happen is there will be an increase in the joint space. The normal joint space here is less than 2 millimeters. So all of these carpal bones, as one can see, are very close to one another. So if there is a unusually larger distance, and if measured more than 2 millimeter, then it is a sign that there is scapholunate ligaments, a ligament tear. So if there is this tear, there will be this increased distance. And again, to not miss this, you have to know what movement is limited, what movement is not easy or not comfortable for the patient to actually do, and you have to know the mechanism of injury. You have to know the complaint. You have to know a lot of the entire detailed history for you to be able to detect this if you're new to radiology. So again, as much stress as I can place on the fact that history plays the most important role in diagnosis is, I can't stress more on it, because it's very important to never lose the importance and never stop giving importance to what the patient is telling you, and what is and how this how the injury resulted, the mechanism of it. So all of it plays a part in the final diagnosis, especially if you're new to it. So now let's see here. So it says widened scapholunate space, which like I said, is normally less than 2 millimeters. So if it's more than that, it's a widened space. So it indicates a torn scapholunate ligament. Now we're going to talk about TFCC. We have talked about it in detail as well. Let's just repeat it real quickly. So again, this is the carpal bones and the radius and ulna. So let's name them again, because can't stress enough on this, because it's very confusing. So this again is scaphoid. So scaphoid, lunate, tricutrium, and pisiform is not visible here. Again, from lateral to medial, let's go. So this is trapezium, trapezoid, so TM before TZ. So because M is obviously before Z. So TM, so trapezium, trapezoid, capitate, and hemate. Finally, we've got it. So I hope everybody has memorized this as well. So now the 4 ligaments that make the TFCC or the TFC complex are, like we talked about it before as well. So it's ulnar collateral ligament, it's the radio-ulnar ligament, it's the ulno tricutrial ligament, it's the ulno-lunate ligament. So if any of these are damaged, then the resultant injury will be that there will be instability of the joint. The ulnar deviation will be almost impossible, because it will be very, very painful. And it is basically how it'll present. It'll also be presenting with some soft tissue involvement, like some swelling, bruising. So bruise will be here. So this is the place where the bruise will be. So The TFC bruise will be here on my knuckle, close to my knuckle. So again, tricutrium, we talked about this. This is the triangular fibrocartilage complex, which is the TFCC. So this is ulna, obviously, and then we have lunate, which is also forming the ulno-lunate ligament, also part of the TFC. So, and then we have radius. So now we're going to see how that appears on an MRI. So we're going to talk about a T1 MRI. This is a fat suppression. So there is a complete, now because the last that we discussed, there was a rupture of the ulnocollateral ligament on all three upper ligaments. So here there is a complete rupture of the radio-ulnar ligament. So which is visible here. So this is a complete rupture here of the radio-ulnar ligament, which is also part of the TFCC. Other ligaments appear to be normal. So this is the ulnar collateral ligament, which appears to be normal, and everything else appears to be fine. So there is a complete rupture of the radio-ulnar ligament. Now we're going to talk about metacarpals. So there are 5 metacarpals. So these are the bones that are joined proximally to the carpal bones, the upper row, more specifically, and the distal portion of the metacarpals are joined with phalanges. These are 3 sets of phalanges and 2 for the thumb. So these are the 5 metacarpal bones here. These are forming metacarpal phalangeal joints, and here, because we have a complete radiograph, finally, let's discuss this. So this is the proximal interphalangeal joint. This is the distal interphalangeal joint of the 5th finger. This is the 1st, 2nd, 3rd, and 4th, and 5th. So this is how you number the fingers. So it's 1, 2, 3, 4, 5. So it has 2 phalanges. The thumb has 2 phalanges, and all the rest of the fingers have 3 phalanges, making 2 joints. The proximal interphalangeal joint and the distal interphalangeal joint, and this joint here is the metacarpal phalangeal joint. So now we are going to focus on, now I think we can not focus on this, and I think everybody would at this point know which bone is which, and this is obviously radius and ulna and all the carpal bones, and so let's focus on the metacarpals. So the most common type of fracture that is seen in the metacarpal bones is actually an oblique spiral fracture, which is present here on the 3rd and 4th metacarpal here. So this is an oblique fracture, oblique spiral fracture. Also here, so this is a complete fragment but not displaced. These are the 2 fractures of the 2 fingers. So now we're going to talk about dislocated PIP. So PIP dislocation, again, is a rare condition, but the 2nd and the 3rd fingers are susceptible to it, and but still it's rare. I've never seen it, but well, this is a radiograph of it. So this is the 3rd finger. So this is the metacarpal phalangeal joint, and this is the interphalangeal joint, or the proximal interphalangeal joint and the distal interphalangeal joint. So this is a dislocation of the proximal interphalangeal joint, and we can see this and this swelling here, and obviously the bruising won't be visible on radiograph, but there's probably a big bruise on the man's or the woman's finger, probably a man's x-ray. So important thing to note here is that this is a dislocation, and let's just go back and before we name this dislocation as to if it's a medial or lateral dislocation, let's just go back and revise again. So this is the anatomical, and in anatomical position, the thumb is pointing outward. So this is lateral, and this is little finger is medial, right? So this is towards the little finger, so it's medial, and if it were towards the thumb, it would have been lateral. Because we can't see the radius or the ulna, so let's just so for here we should remember that the thumb always points outward when in anatomical position, so it's lateral, and the little finger is or the fifth finger is medial. So if it's towards the medial finger, it's medial dislocation. If it's towards the thumb, it's a lateral dislocation. So here it's a medial PIP dislocation of the fifth finger, of the third finger, I'm sorry. So this is the third finger. Again, let's do it again. So it's a medial dislocation of the PIP, or the proximal interphalangeal joint, and it's a medial dislocation, and it's the third finger that is involved. So that is how dislocation of the proximal interphalangeal joint will appear on a radiograph, and that is how you name it. If it's towards the medial or the little finger, we call it medial. If it's towards the thumb, we call it lateral dislocation. So it's a medial dislocation here of the third finger. It's involving the proximal interphalangeal joint. So now we're going to move to the chronic conditions. So dislocation, fractures, ligament tears, those were all acute conditions. Now we're going to talk a little bit about the chronic conditions. They will involve all the arthritis of the joint, and because in arthritis like RA, the first joint involvement is of the hands. Hands are mostly the first joints to be involved in rheumatoid arthritis. So in osteoarthritis, we're going to discuss osteoarthritis, rheumatoid arthritis, a special psoriatic arthritis, and some other conditions in the chronic conditions. So let's see the radiographs. So this is a radiograph of an old individual, and this is showing a chronic condition in which we can see that there is this unusual osteophyte formed here. So this is and with that there is a soft tissue mass here. So this is present here, but if you look at the radiograph, there is sclerosis. There is a decrease in joint space. So this appears to be decreased joint space, and there appears to be decreased bone mineral density here. So, and this is an unusual osteophyte here. So, but the main focus, let's just focus on the soft tissue. So there is a soft tissue lesion here, and there is no calcification of it, because if there were any calcification, it would have been visible here. So this is a chronic condition. This is a radiograph of an old individual, probably above at least the age of 55. 60 probably, and the focus is on the soft tissue, which the boundaries of which can be visible here. So these are actually the boundaries here. These are the boundaries of the soft tissue, and this is the outer boundary. So this is the soft tissue mass here, but we can also comment on the rest of the radiograph as well, and there are a lot of changes. The sclerosis is visible and everything that we've just covered. So now again, the modalities, we're going to look at different modalities. So before talking about abnormal, let's just see, this is the normal, which we've discussed in detail, but there is a little bit of sclerosis present, but this is a normal presentation. So this is a normal x-ray. Then we have an avascular necrosis. Okay, so lunate, the carpal bone lunate, is actually susceptible to avascular necrosis. Let's just go back into the anatomy a little bit. So the radial artery is going here, and the ulnar artery, they're forming the superficial and the deep palmar arches, and those arches are giving a blood supply to the carpal bones, right? So the radial and ulnar branches actually supply these bones. But if you form like a superficial or deep arch, you will see that because the lunate bone, like I said, the tricutrium and the pisiform are pushed medially, and lunate appears to be in the center. in the lower row of carpal bones, right? So scaphoid, lunate, tricutrium, and pisiform, right? So lunate appears to be in the center, like here. So this is lunate appearing to be in the center of the wrist joint. So actually, let's just explain it. It's better that I explain it here. So let's just suppose that there is an arch here of the radial and ulnar artery forming the superficial and deep palmar arches. The arches won't be close to this bone here or here, the lunate bone. They're not going to be close to it. So they're going to be like this and like this, right? So deep and superficial, but they're not going to be right above or below this bone lunate. So that is why it is possible for the blood supply to be disrupted. A number of reasons can be cause of this disruption, and as a result, avascular necrosis of the bone will slowly develop because if the blood supply stops, it's not an acute condition that the bone will just die because of not an adequate supply of nutrients. So it's a slow process of necrosis. Necrosis actually means this the death of the tissue. So avascular necrosis, if any tissue of our body, be it bone, be it any other tissue, if it's not supplied with blood and nutrients, it eventually dies. So avascular necrosis will be if the blood supply is disrupted due to some reason, and the bone and the resultant tissue death. So that is avascular necrosis, and we call it Kienbock's disease when the lunate is actually the bone that is necrosed because of avascular changes, and that is this disease which is visible here on the radiograph. There is sclerosis of the bone. This is an individual who is old, and here, so there is sclerosis of the bone and sclerosis here as well, and this is the entire lunate bone is sclerosed and is showing that it's not normal. So because all the rest of the bones are not like this, so there is increased activity here, so it's necrosing right now. And then we have degenerative joint disease. We can also call it osteoarthritis. So here it's a degenerative and inflammatory arthritis. So what happens, all the same characteristics of osteoarthritis: joint space narrowing, sclerosis, osteophyte formation, cartilage degeneration. There will be increased friction, which will again result in some osteophyte formation or further decrease in joint space, and further the degeneration of the cartilage. So it's a ongoing, progressive disease, and you can't really ever stop it. You can slow it down. You can slow down the progression of osteoarthritis. You can't really ever stop degenerative disease of this intensity. So this is the degenerative joint disease. Obviously, we can see here the joint space is visibly narrowed or reduced here. There is increased sclerosis everywhere. There is increased sclerosis, and the joint space here is narrowed as well. So that is the picture of how a degenerative inflammatory bones appear on radiograph, and in this case we're talking about the wrist. So these are the carpal bones, and the first metacarpal and the other rest 4 metacarpals, the radius and ulna. All of them are involved, and all of them are showing signs of degeneration. So now we're going to talk about bone tumors. So bone tumor is also commonly, or any tumor is also commonly called cancer or cancerous tumors. So bone tumors are sarcomas. These are this is actually a picture of endochondroma, which is the cancer or tumor of the cartilage. So endochondroma or the enchondroma, which is also called endochondroma or enchondroma. So endo will be inside. So this cartilage chondrus is actually signifying that it's cartilage. So endochondroma is the cancer of the inside of the cartilage. So the outside of the bone is cartilage. So all the cancerous activity, what is cancer? Cancer is the excessive growth or excessive multiplication or excessive division of cells, right? And it's uncontrollable division of cells, right? So when this uncontrollable malignant cell division starts, actually endochondroma is a benign condition, it's not malignant. So whenever this cancer, but cancer is cancer. Even if it's benign, it's just dividing, it's unstoppable dividing. So this division, if it's happening inside the cartilage, we call it endochondroma. Like I said, it's a benign condition. So this actually is a radiograph of a young child. So remember, endochondroma or any type of cancer has no age limit, so it can develop anytime. And or the enchondromas are seen to develop early on in age, and there is visible deformity of the joint, and if not deformity, big visible osteophytes, and they are very painful, and they continue to grow in size as well. So these are some of the characteristics of an enchondroma or endochondroma. It's actually a benign tumor of the cartilage, inside of the cartilage. So now that we've talked about the cartilage tumor, we're going to talk about the bone tumor. So bone tumor, if malignant, is known as osteosarcoma, and let's see how that appears on a radiograph. So on a radiograph, the osteosarcoma, what is osteosarcoma? So any cancer is actually uncontrollable division of the cell, but the cells are dividing and not differentiating. So they're not functioning cells. They have no function to perform other than dividing, and they're just uncontrolled. There's just uncontrolled division of cells. So that results in cancer. So it's a very painful condition here, and there will be no movement possible of the index finger or the second finger. So this is the first and the second. So this is the second finger. This is the second metatarsal that is involved, and it's a very severe condition here. So sometimes what we do is we take out this entire portion of the cancer cell if there is chance of if there are no chances that it will metastasize, and then we take this entire cancerous bone out. Otherwise, if there are other mets here and there, or if a lot of different bone is involved, then there isn't really any option of osteotomy. So there are different treatments to it, but you can't really ever cure cancer. So this is bone tumor of also called the osteosarcoma or the giant cell tumor. So now we're going to talk about two conditions, the osteoarthritis and the RA, and how they're different from one another. So first, we're going to talk about osteoarthritis. So the degenerative joint disease, also known as osteoarthritis. So like we discussed just now, in osteoarthritis, what happens is that we have increased osteophyte formation or increased activity of bone forming cells close to the surfaces, also known as sclerosis. So there is sclerosis. There is the main feature of osteoarthritis is basically joint space narrowing and the friction that is created because of movement, which further degenerates the joint and the cartilage is lost. So all of this entire cascade of osteoarthritis is all the characteristics of the disease. So here we can see the osteophytes here of the first metacarpal here, and also here. So this is osteoarthritis. There is sclerosis everywhere. So there is sclerosis and there is obviously joint space narrowing. There's almost no joint space here. So, and the joint space is narrowed here as well as visible. But here the joint space can't be actually predicted if there is any joint space narrowing, because it's actually a lateral view, so you can't really comment on this area, but there is a reduced joint space here and obviously here. This appears normal, but there is degenerative changes visible on this and all of these bones. These appear comparatively normal, but this is involved and there is degeneration of all of these bones here, the carpal, the radius ulna, and the first metacarpal. Now we're going to, so like I said, there is large marginal spurs, or you can call them osteophytes. So these are close to the joint surface, or these are actually right next to the joint here. So these are the joint surfaces making this first metacarpal, this carpal metacarpal joint here, the first carpal metacarpal joint, the first one, real tongue roller there. So this is involved. This is actually the osteophytes close to this joint here. So then we have rheumatoid arthritis. So rheumatoid arthritis is actually an autoimmune disease, and we're going to have to give it a little bit more time as well because it's really hard to understand. So first, there are two types of deformities. There is Bontinet deformity, in which the proximal, which is actually prominent in the thumb, what happens is that this will move out. So there will be a bend in my first interphalangeal joint. So bend means that this will move towards my palm of the hand, and then this will move away. So this formation this is actually a Bontinet deformity. And then we have a swan neck deformity. In a swan neck deformity, what happens is that this will be inside and this will be here. So this is a swan neck deformity, both characteristics of rheumatoid arthritis. What happens in rheumatoid arthritis is that the small joints are involved first. So Bontinet is commonly seen in the thumb, in which the PIP will actually be bent towards the palm and the DIP will be to outside. So this will be Bontinet, again repeating. And in this, the exact opposite is happening. So what is happening is that the proximal is moving away. So this is moving away from the palm of my hand. So let's just do it here. Moving away, and this is moving. So if it's like this, then this will be a swan neck deformity. So this is moving away here, and then in my DIP is moving towards. So this will be a swan neck deformity. Both of these deformities are seen with RA. And what happens is that there is medial deviation of the phalanx. So this is characteristic hand features of RA disease, which is an autoimmune disease. There are characteristic bunion formation here. So this will be swelled, and also this will be swelled as well. So bunions are also characteristic of RA. They can also be seen with OA, but OA has its own characteristics. So that was a little bit about the chronic conditions involving the hand, the osteoarthritis and the rheumatoid arthritis, and how they present on the hand. So the two deformities to remember: the swan neck, mostly present on all the fingers other than the thumb, and on thumb we see Bontinet deformity. The two deformities of RA. So now we're going to talk about more the degenerative joint disease. So like I said, what will happen first? There will be joint space reduction or narrowing joint and narrowness in the joint surfaces. Then we will have osteophyte formation. We discussed this as well. We also saw how osteophytes appear on radiographs. Then there will be sclerosis. Sclerosis is that these joint surfaces or the bone surfaces will appear brighter because of increased activity of the periosteal activity, because of the increased osteal activity, which is not good because it'll be replaced by osteoclastic activity, which is not good, which is actually going to eat the bone. So sclerosis, and then we have loose osteocartilage joint bodies, which we also saw just now. So what is the difference between osteophytes? These are bones, and then osteocartilage is like cartilage and bone mixed. So these are within the joint surface, and osteophytes are actually outside the joint surface somewhere. And then we have subchondral cyst. Subchondral cyst can also be subchondral will mean between or below the chondral line, right? So a cyst formation there will be known as subchondral cyst, which is also a sign of degenerative disease. So these are all the characteristics of degenerative joint disease, or the OA. And for RA, we saw what deformities can occur on the hand of an individual suffering from RA, which is an autoimmune disease, I repeat. So again, we are talking about arthritis again, which is a special one. So psoriatic arthritis it is. Psoriasis is actually redness of the skin with a silvery, scaly appearance on top as well. So when this psoriasis is accompanied by arthritis, then we call it psoriatic arthritis. And what happens is the arthritic changes are similar to OA, but there is accompanied skin involvement as well. So it is more painful and the movements will be much more limited and much more painful than they were in simple osteoarthritis, when only the bone was involved. Now the bone and the skin on top of the joint or the bone is also involved. So let's see how that appears. So again, the skin, because it can't be visible on a radiograph or an X-ray, so we can't really see the psoriatic changes on the skin. But like I said, it'll be a reddish skin with silvery, scaly appearance. And the underneath osteal changes will be same as they were in OA or the osteoarthritis, joint space narrowing, all the characteristics of OA that we just discussed. Sclerosis or osteophyte formation, osteocartilaginous body formation within the joint surfaces, which will further increase the friction. So as we can see, there is joint space narrowing here, almost no joint space here. So all the same features. And on top, skin involvement. So that is worse than OA. So in the end, the last chronic condition that we're going to be discussing is ganglion or ganglionic cyst. What happens is that when a tendon, mostly when a ligament is ruptured, what happens is the contents are expelled out, and there is a formation of a sort of like a cyst under the skin, and it's bendable. It's actually you can actually like pinch it, and it'll actually be pinched in the new shape, will stay for a little while. Those are the characteristics of a ganglionic cyst. And there is like a jelly-like substance underneath the skin, which you can feel that it's movable. And so that's all about it. Let's see how it appears. So this is the substance here, which is because of some rupture accumulated here, and so this is a coronal T1, and in this fat has been suppressed, and this is the ganglionic cyst, which is actually this in area here is sort of like swelled here because of this. This is abnormal, obviously, and this is a fluid that is transparent. It is gel-like, and it is when you pinch it like this, it kind of for some time it can actually bear that shape. So this here, so this was a this was a cross sectional, and now this is a coronal or a frontal view. And as we can see here, this is a cyst formation here. So this is the first metatarsal and the carpal bones here, and these are the rest of the flexor bones. So this is this slice or the coronal view here, and this is the ganglionic cyst. And that is it for the chronic conditions. Now, this was the end of the chronic conditions. We discussed the arthritis, different types of arthritis, and we also saw the ganglionic cyst and how it appears. It's very, very uncommon and very rare. Rarely seen, and it's more common in females as well. So that was the end of the chronic conditions as well. So with that, I will end today's entire lecture. That's it for today. Thank you for watching sqadia.com.